Hi, I'm Brad Morrow, Senior Vice President of Sales with 3D Technology Group. We are a national information technology services company dedicated to enabling every healthcare organization to achieve more. As a trusted healthcare partner, we help clients optimize both clinical and operational performance through our professional and managed IT services. We're committed to exceeding client expectations for quality and service by defining, designing, and deploying real working solutions that deliver value every day. We work across the country with some of the largest healthcare organizations to provide services around mergers and acquisitions, new construction, EHR and ERP implementations, technology refresh, engineering on demand, and IT strategic planning. We're also a proud sponsor of Tennessee HIMSS, and I'm honored to introduce our next session, Healthcare in America, The Long-Term View, moderated by Dr. Mark Frisse. Dr. Frisse is the Accenture Professor in the Department of Biomedical Informatics at Vanderbilt University Medical Center. His work focuses on the intersection between healthcare informatics, economics, policy, and healthcare transformation. Please join me in welcoming Dr. Frisse.
My name is Mark Frisse. I'm from Vanderbilt University, and I'm the moderator of this panel. The idea of this panel was to look toward the future, and in light of the pandemic, we are going to emphasize that in particular. Our participants for the panel include Troy Emmett from Fortinet, one of our program sponsors, Dr. J. Mark Overhage, who has served in many capacities and currently is an independent consultant, Mr. Chris Sakalowski, who is at Google Cloud, and Shanna Swafford at Blue Cross Blue Shield of Tennessee. Robert Morris will also appear in some parts of this. He is the representative from HIMSS who's been providing recording of these panel discussions. Let's look at the implications of the pandemic on people. We've had over 225,000 deaths in the United States alone and 1.2 million confirmed cases as of mid-October. We have a significant amount of individuals who are suffering from chronic symptoms and illnesses as a result of their COVID infections. Americans are postponing routine care and probably postponing some serious acute medical care as well. Americans have lost their jobs. The unemployment rate in mid-October was 13%, up from 3.5% prior to the pandemic, and we suspect that to increase as the pandemic continues. Americans are depleting their savings. The number of people who have no savings at all now is very high in the United States. Because our system is often reliant on employer-sponsored insurance, many have lost their health care coverage, and we anticipate overall higher health care costs over time. Employers have lost revenue. Almost every employer has, and for many small businesses in particular, they are closed, many permanently. Every employer has been forced to transform its business model because of the change in distancing practices. Customers are also changing their preferences. Many more people are becoming familiar with online purchasing, online transactions, video conferencing, and many other behavioral patterns. Employees also are changing their practices because they're working from home a lot. And the question is whether or not these practices will persist. Certainly many will, and so we anticipate a lot of workplace transformation in the years ahead. State and federal government are in dire circumstances. States and the federal government have lost a lot of tax revenues. The economic stimulus expenditures, particularly at the federal level, are leading to massive long-term deficits. At the state level, there's far less money for Medicaid, and at the federal level, there's much less federal wiggle room to increase Medicare. And the federal government and states in general have limited fiscal and monetary options to address with this crisis. Providers and health plans are also suffering. Both are seeing lower revenues. Both are seeing higher costs. There are greater employee burdens, both at providers and health plans, because of the workplace disruption. And there's great financial uncertainty as to how these business models and financial models will change over time. In particular, with the entry of new disruptive players, one is not sure. One thing is certain, though, and that is the status quo is no longer acceptable. So what's the story for health information technology? Well, I think it's an area of great opportunity. The rapidly changing business models and customer preferences and employee preferences are going to drive inevitable business transformation. Technology really can't keep up with it, and so nimble players may have an advantage here. Everyone is suffering from administrative complexity prior to the pandemic, and it's difficult to understand how all of this administrative complexity can persist after the pandemic is over. And another thing to ask yourself is whether or not the current technologies we use every day are best suited for the challenges ahead. That's an open question. One thing is certain, though, and that is the status quo is no longer acceptable. Our panelists are going to look at these issues in greater detail. And again, they're Tori Ament, Mark Overhage, Chris Sakalowski, and Shannon Swafford. Let's turn to their views now. I'd like to just start with Chris and say, Chris, you have focused on a lot of technologies and a lot of areas that are really accelerating. Could you comment on what you've been doing and what you've been seeing?
Yeah, sure. First of all, Mark, thank you, and thank you to my colleagues for joining me today, and to all the Hinge Tennessee members. It's great to join you at this medium. As the managing director for Google Cloud's healthcare and life sciences business, I think we recognized early on that this was going to have a profound impact. This being defined as the pandemic, and we had been having this conversation a year ago. I think we'd be talking about dramatically different topics, and certainly with the pandemic still, at large for us as a society, there's much that we take away from it. I think one of the first things we saw when we saw the pandemic as a whole was its impact on access to care. Right, and so one of the lasting impacts that we saw short term was the inability to get access to care. It physically kept us away from our care professionals and care teams. And we also saw the need to get access. And so we saw this growing category, first as point-to-point video capability to connect with the care teams. And we also saw, and I know some of my colleagues will talk about this a little bit later, the rise of remote monitoring, via devices, this next generation of home care and home remote monitoring capability. We saw those as short-term impacts. What we actually had the time to do, though, since we've been in this for such a long period of time now, as many leaders that we work with day in and day out have had a chance to step back as we've gotten to some level of steady state in terms of using point-to-point video capabilities, remote monitoring, is we've had the opportunity to step back and say, what does this really mean for us? And I said it earlier, I'll say it again, access, not only short term for those who needed immediate medical care, but as we step back from this, access in terms of there's trust being built in these technologies with the clinicians, with consumers, and the ability to meet them where they are, where they need care, Mark. And so just with that in mind, one of the first things we saw is sort of a lasting benefit of the pandemic, if you could take anything from this worldwide tragedy, is that it's built trust in consumers, clinicians, and care teams in a new virtual engagement model, the ability to remote monitor them at home. And we've seen a rise in new models of long-term patient engagement, whether it be chronic care, mentally or physically, whether it be hospice in home. And it's opened up new economic models for our insurers to consider, for providers to consider, and even our pharmaceutical organizations in terms of the way they think about clinical trials. All of those things are coming into fruition. So it's been quite a journey for us, and we have a long way to go. But watching that emerge, access has been the greatest thing we've walked away from in terms of the pandemic thus far.
Well, Chris, you mentioned access and trust, and that's critical. I wonder if I could just ask Shannon for an anecdote or two about how the same thing is affecting her work. Chris, you mentioned access and trust and the impact that has had and the acceleration, and you mentioned broader care networks and relationships. I wonder, Shannon, could you introduce yourself for just a minute and tell us what you believe is happening in terms of health plan provider partnerships?
Sure, I'm Shannon Swafford. I currently work for a health plan, so I'm happy to give just my view of what it looks like in our ecosystem today, just in that sector. Even before the pandemic, there were health plans partnering with or purchasing clinics and physicians' offices and tech companies to increase their footprint on the availability of remote patient monitoring and things like that. And so we saw one health plan bought a tech company called Heal, and it was specifically for the purpose of remote patient monitoring for their chronic disease population. I expect that will continue and go beyond the chronic disease population and will manage acute care. And just recently, I saw where CMS had increased or had approved to pay cardiac rehab and some different things just this week via telemedicine delivery. And so there will be more and more purchases, I believe, and partnerships, collaborative partnerships with companies that can provide and host telemedicine visits as we continue to increase that coverage.
But what's it going to look like for providers in the next few years?
Great, thanks, Mark, and thanks everybody for the chance to chat today. It's always good, and especially when we're a little more isolated than usual, to get a chance to virtually interact with such a great group of folks. So providers, I think a couple of things are going to be very important. One is that one of the things that's different about this pandemic from some of our other public health urgencies and crises over the past couple of decades is it's long. It wasn't there and gone in a month like SARS or some of the other things. And so I think that is driving more of an impact than perhaps we have seen with other kinds of situations like this. And so I think there's a couple of areas. One is that partly for the reasons Chris talked about, and there's been a willingness to try things that simply wasn't there. And I think anybody who's come from outside of healthcare into healthcare has been challenged by the conservatism, the methodical pace at which things happen, the long sales cycles, et cetera. And we saw things happen in days and weeks over the last 9 months that often would have taken much, much longer. So I think we've begun to open the door, and Chris kind of alluded this a bit, to experimentation of various kinds, to trying things and not being quite so stuck in the way things were done. Having said that, not all of those trials were successes. Lots of things broke, lots of things that didn't pan out the way people thought, lots of things that didn't work. But of course, that is the way that a lot of companies learn and evolve. That's been healthcare's tradition for learning and evolving, but I think maybe we got a little taste of it, maybe have a little more opportunity to take that forward with us. The second thing I think that is particularly important is that we're seeing it's really, in my mind, a continuation of the shift of payer mix. So with people unemployed, with increased roles in Medicaid, and fewer people with commercial insurance available, the continued cost pressure, there was an aspiration for many health systems was to be able to make money at Medicare rates. And it may be that we're seeing people head in the direction they're going to have to make money at Medicaid rates, which are something in most states 80% or something like that of Medicare rates. So a pretty big delta, partly because there's just more people at that level, fewer people in that offsetting income from commercial insurance, which there was a great study Rand just came out with a week or two ago that sort of looked at these rates. And across the country, if I remember right, commercial payers are about 240% of Medicare across the country. Some states 350% of Medicare. And so you can see how that balancing act was happening with Medicaid, but that starts to fall apart with this economic shift. And so I think two things will come out of that. One is that there will be continued pressure to move in the direction of value-based care. And part of that will be driven by the fact that I think providers will be looking to take first dollar more frequently to become plans of various kinds, whether those are ACOs or various kinds of structures, because they're going to have to in order to make the economics work. If they let the traditional payer have that 10 or 12% administrative cost and they're going to struggle even more. So I think it's going to push providers to look at ways to operate plans and take that first dollar. And then the last thing I think I'd highlight is that we've decided, and telehealth is an example, healthcare IT is another example. There are virtual EMR implementations happening where in the past 150 people would have descended on the health system and been the help at the elbow or run the war room or whatever. It happened virtually and it worked. And so you got to think that the costs of managing and operating some of these systems might be driven down a little bit more, even if you take the simple thing like, well, we didn't have to fly 100 people into wherever the implementation was. And hopefully some of the, like the VA and the DoD, for example, that are going through a whole host of implementations over the next 10 years might mightily benefit from that, which would be fantastic. So, but even just core day-to-day health IT operations, I think we've opened up more willingness to work virtually and collaborate virtually, which is changing the mix and the challenges of hiring and bringing people in. So I think those are three big areas that we're seeing: willingness to experiment, increased pressure on the top line revenues and how to be functional at that, including plans, and then increased ability to function virtually in these challenging times that will carry over.
Several of you have alluded to new forms of devices as well. Chris, would you want to comment on the innovations you've seen?
Sure, Mark. As we were talking about in the virtual green room, what we've seen is, and I think Mark highlighted this, the fidelity of care, the quality of care versus virtual versus physical. There still is a chasm. It's closing, and it's closing quickly, and it's closing because of the onset of new technologies and new capabilities. They say new because they may have been out there, but they've really been put into the spotlight. And you've seen companies like TitleCare and investments by Amwell and TitleCare, and there's a reason why. Companies like Amwell, who deliver telehealth right at scale, need companies like TitleCare to deliver that in-person experience, but by yet sending these kits, these applications, these devices home to get that same comprehensive analysis, the diagnosis, and ultimately the data that's needed for clinicians and care teams to make the best recommendations, either at a point of care or for long-term care to predict and prevent and ultimately intervene in someone's care path. So we've seen quite a bunch of those companies go up. And by the way, it's for one of the main reasons why we struck our partnership with Amwell, is because we could see the progression of that telehealth platform being so purpose-built to ingest those devices and new applications that would ultimately bring that and close that gap of parity between on-premise, on-site care and at home and all remote and distanced care. And so we're very, very excited about what we're seeing.
Are health plans excited about this, would you say? Are they also fostering this kind of innovation?
So excited, is that the same as anxious? Yeah, so yes, I think that some plans are excited. I think that if you have in one of your clinical sectors of the payer, because a health plan is a huge organization with many facets. So if you're looking at it from the clinical care management aspect, I think that some health plans are very excited about the potential of starting with their chronic disease members, so that they can increase their care management. Some of the barriers, I think, are what wearables do you approve? What remote patient monitoring devices meet a standard of ISO standard or any kind of standard that calibration can be trusted? And then you also have to, it's a lot of complexities to it, simply because we are not, as health plans, normally receiving that data from the member. That is generally going through the provider to the EMR. So depending on your level of contractual agreement with the provider, you may or may not be getting that particular data. Some of it is very limited clinical documentation exchange information, just some structured things like LOINC and SNOMED and things like that. Some have progress notes, more information than that. So it can be some. I would say that the answer is some health plans are very excited. But all of them are nervous about what's the right choice. And another question is, does a payer or a health plan partner with a particular company and have that company provide all the wearables? So that's a partnership that could become important. But then, are you limiting innovation and opportunities for your members to accept what works for them or what's compatible with their particular devices or their broadband at home strong enough to transfer that data?
Troy, what's your perspective of the discussion so far? What are you seeing, and what are your concerns?
Yeah, so Mark, thanks for having me. Troy Emmett with Fortinet. Spent the last 15 years in healthcare and excited to be able to represent Fortinet. But it's interesting. So these virtual video patient experience platforms have been out for some time, and in my experience, at the organizations I was with previously, we would do 50 to 100 patient video visits a month. And those same organizations now are doing 45,000, right? And we're using many different connected devices. Chris mentioned TytoCare. That was a solution that my organization implemented about 3 years ago. Really exciting at the time, but now it's something that we can actually use, that has a really good use case, right? But what does that do for the attack surface, right? So many health systems are putting in these systems very quickly, and it's important for them to be looking at the risk and doing strong risk assessments, making sure that their organization is protected. So not only protected from something like a denial of a service where the service could be disabled and they wouldn't be able to service their patients, but also losing data. Also looking at third-party risk, right? So a lot of organizations are partnering with third parties to turn on these video visit type environments, and it's really important that organizations are evaluating those organizations, looking at them, and just making sure that the risk is right for their organization. Yeah, I think it's different for everybody in the ecosystem, right? So in the provider space, I think those organizations have a lot of control over the technology that they're implementing and making available to their patients. And it's really important that they have strong IT governance and ability to do strong risk assessments so that when they're bringing in that technology, not only is it a great patient experience, which we know they are, which we've learned through the pandemic, this is a great scenario for opening up access to patient care, but also making sure that along with it they're adhering to their HIPAA obligations and protecting that patient data.
And I think Troy nailed it. I think it's going to depend on what the scenario is, but I think what has risen to the top of the discussion board in terms of the pandemic and what it's driven and what it will leave us with is healthcare and consumerism merging. I think, quite frankly, the consumers have demanded this of their banking systems, of their retail systems, and pick X industry, and we've seen it. And the reality is, Mark, the consumers will demand it. Where you have more control, to Troy's point, is if you're sending home a self-diagnostic kit as part of a prescription, hospital systems will have the opportunity to choose what those kits and devices and applications are. Where they don't is, as Shannon was mentioning, is the wearables. You're going to need to deal with Android watches and watches from Samsung and Apple and all the different ecosystems, and that's the ante to play as consumers take more control of not only the data itself but of the experience, and they want a connected experience, and they want us to meet them where they are. And so I really think at the end of the day, the consumers are going to drive that end X experience, and again, you'll see a fusion of control and meeting the consumer where they are.
What is this complexity going to do in terms of our notion of an EHR, and how's that going to impact overall how teams, practitioners are going to conduct their affairs?
First of all, I think we have a ways to go in terms of understanding these data. If you start measuring, as you said, people tracking their heart rate continuously, or you're doing, whatever it is that you're doing, blood pressure is being taken at home 5 or 6 times a day. Clinically, we don't know what to do with those. There's a really nice study that I did with Paul Tang several years ago looking at home blood pressure measurement. and we would see these blood pressures of 180 over 130 from people at home. Well, it was during the Mets game, and the Mets were losing, and and the guy's blood pressure back. We don't know what to make of those things, and so I think we've got a lot of clinical discovery to do. And one of the risks, and I think we've seen this in some of the wearables, like the caution, and I think appropriate caution around oxygen saturation monitoring that some of the devices are doing. And how do we interpret this data? How do we use it? And when you bring it to your provider, they don't know what to make of it. I can look at that. So I think the second part of this is, this interpretive part, and not only that, but the chronic monitoring that we can do because of these continuously connected devices, both has a lot of potential because maybe we can see trends and predict things. But it remains to be seen. It remains to be demonstrated. And I think we got to be careful not to rush ahead. And, I've certainly had patients show up in my practice with, their glucose is all charted out and things like that. And I'm like, yeah, let me eyeball the morning blood sugars, the evening blood, that's what I know how to operate on. So I think that we'll see that. The other thing that you allude to, though, is the connectivity, interoperability. And obviously, many EHRs and other population health platforms have had the ability to ingest and incorporate these data for some time. Like Cerner's Healthy Intent platform, you can stream your Fitbit data into or whatever. There's a lot of really innovative, nice little companies, Doc.ai, who can you hook up your various services and aggregate your data. Very cool. But at the end of the day, we are going to have to come up with better algorithms, better synthesis of that data, because knowing your heart rate continuously for the last 4.5 years just isn't interpretable by a human. So we're except in the extreme cases. So I think we're going to have to see a lot of work in the AI realm, in the machine learning realm, and then clinical trials that prove what those things look like and mean before we get too wrapped up in the idea that we can sort of do everything, because it just doesn't mean the same thing as a blood pressure taken in my office, with 3 repetitions with my sphygmomanometer. It's not as useful, frankly, I don't think, as a blood pressure taken 10 times a day from somebody walking around at home. But I've got 100 years of history of what to do with that blood pressure in the office. And we're babes in the woods when it comes to those blood pressures taken continuously at home, just as an example of the many kinds of data that we're starting to acquire.
Well, what several of you are saying here is really that these technologies are turning our notion of analytics on its head. If you would ask a lot of people 2 years ago, they'd say, well, we use all this stuff with EHR, conventional things, and we throw it in a big data warehouse, and then we try to figure out what the trends are. I think what a lot of you are saying now is one critical role for trusted AI and analytics is on managing the inbound data in a trusted way so that it can be summarized and people are getting something out of that. Anybody want to comment on that?
Mark, I loved what you said, which is, what do we do with the data? And I think there's artificial intelligence and machine learning are going to play 2 critical roles. The first one is a partnership with the docs and the clinicians, right? As they start to think through those algorithms, and they start to think through, and they can work with machine learning data scientists, and they can start to do that, predict, that detect, and ultimately the intervention, right? What's the care pathway that this thing triggers? I mean, we've been doing it for years with cars, and we're just at the early stages of doing it with patients and consumers, both ones that come in episodically into the health system versus ones that we could be monitoring them in over much longer periods of time, whether they have a chronic disease, a mental health issue, or whether it's just someone that is healthy today that we want to make sure we follow them throughout their healthy journey and steer them when they might be coming off of it. That's the first role. The second one is, what role does artificial intelligence play in that care continuum? Meaning, you can't just throw more work on a doctor. You can't throw more work on nurses. We're already talking about shortages in both of their fields and the overwork burden that they have. And so what role does artificial intelligence play as digital agents, right? Where that machine learning algorithm in partnership with a clinician says that something's happening either longitudinally or episodically with a patient and you want to intervene. That intervention step could be simply sending them a text message to say, have you taken your meds? It could be something more sophisticated like, hey, can you grab that device? We mentioned TitleCare earlier and put it over whatever it is that will scan what it needs and send more comprehensive information back. And ultimately it could hand off to a care team or a caseworker, be it that. So I do think you're going to see that role of analytics, artificial intelligence, partnering and assisting our care professionals to take the burden off of them, right? So they can see the most critical needs, but at the same time, expand our areas and extend our areas to reach those who we now have access to via virtual care.
I was going to speak to predictive analytics, and not from a clinical perspective so much as certainly it's clinical, but from a health plan perspective, as we advance through CMS and ONC's patient access and interoperability rules that were published last year, I guess, were made final, health plans will be exchanging data in a larger and more broad way than they ever have before. So when we are going to exchange data with another plan, because there's a plan-to-plan exchange, and that's clinical data included. So if you're looking at it from a cost perspective, if you don't know for sure the validity or the accuracy of the data that was presented, think of an employer group, a commercial employer group who has a high stress job, and we're looking at their blood pressure, their level of anxiety, or whatever it may be. When we transition that and exchange that information from plan to plan, that new plan is going to quote premiums based on what those data look like. And so from just a cost control perspective, wearables could do a lot clinically, but they could impact you financially from a plan or an employer perspective.
What about the whole interoperability notion? And there's been a lot of activity at the federal level again, and I'm optimistic. I'm sensing real progress for once. What's your read on that?
I agree, and Mark, as you alluded to early, you and I have been fighting those trenches for a lot of years, and I think it's paying off. Certainly, we aren't at the end of the journey, but clearly today, many clinicians have a reasonable set or a much better set of data than they did 3 years ago, 5 years ago, 10 years ago, available about a patient. And that is whether they're going to CVS Minute Clinic or maybe it's a care manager at their payer. And the amount of data that is available to them, there's no question it's dramatically improved. Is it where we need to be? No. Is it well integrated into clinical workflows, much like we're talking about Fitbit data and other things? Not as well. And some of that is, I think, and it's a place where I think machine learning may help us and so on, this long-standing notion or fear of liability, that there's this piece of data in my record, and if I've seen it, I need to act on it, and so on, combined with the anxiety, and we've all felt this, when you're a third-year medical student, the worst thing in the world was when your resident said, what about Mr. Jones' high potassium? And you were like, darn, I didn't know about that high potassium. That is not, and you die with that fear as a doc. And so I think that whole area of how do we leverage the data, as Chris was talking about, is going to be a really important one, moving that forward. Not that we've solved interoperability, but clearly it's not a technical challenge any longer. Clearly it's not a commercialization challenge. Clearly it's not an access challenge. It's not even for the providers, a financial challenge. I think there are some financial challenges buried in there. It's a anxiety on the provider's part. It's an anxiety from a privacy officer standpoint that are the last bits that we've got to fight to the ground. And then if I can take that a little bit further, because we were talking about the consumer, and earlier, Mark, you had mentioned this notion of device, the consumer being in the middle of some of this. With the new interoperability rules and so on, and the requirement with no special effort for API access to clinical data, it's going to be interesting to see how that plays out. I think it opens up some possibilities, both good and bad. But it also, I think, is going to, my personal opinion, underscore what we've seen for a very long time, which is there's going to be a small proportion of patients who are going to deeply engage. They're going to sign up, they've already done it, right? They already have their iPhone hooked up to their providers and CVS and are getting their data and so on. The vast majority of patients just, we don't want to be sick. We don't want, our healthcare to be a major part of our life. We want it just to magically happen. And so I think we're going to continue to see a modest number of patients who engage with those APIs, with these devices, and so on. And the rest of them are going to be happy to, as we all do probably, get advice from our CPA about our taxes, get advice from our financial advisors about our investments. We're going to continue to want to get advice from our providers about our healthcare and not worry too much about it. So I think that the personal level interoperability, it's neat to see those things evolve. I'm not sure how much impact it's going to have. Enterprise level interoperability, I think we're making headway, and it's going to take a while longer to roll out, but boy, is it better than it was 10 years ago.
So authentication is super important, and knowing who's accessing the information, whether it's our providers or our revenue cycle staff, it is super important, and having those access rights within organizations is something that a lot of large integrated health systems, as they're growing and doing a lot of mergers and acquisitions and doing these large EMR implementations, are challenged with. So that's to the core of keeping this data secure, making sure that we don't have privacy breaches, large privacy breaches, because someone might have too wide open of access. Another side of that is the bad actors we're seeing more and more ransom and phishing attacks that are being reported to the OCR every day, and a lot of those are foundationally built on very foundational security practices, such as identity and access management, patching of systems, and that type of thing. So, different health systems out there really are protecting their brand, to keep that trust with their patients, and those things are all just foundational to ensuring that.
Are we going to be able to make it simpler, Chris?
I certainly have great hope on a variety of fronts. First and foremost, to see our regulators working with us as technology companies, with payers, providers, and the pharmaceutical companies and med device manufacturers, just the policies that have come out that allow for interstate commerce between doctors who can cross borders with their specialties, to the reimbursement rates, virtual versus in person. That gives me great hope that when they open up that aperture to do more, that it creates opportunities for all of us on this call and all of the members within HIMSS 10 is to make it simpler. And I do believe we are bringing technologies to the table. We as a collective, not just Google, we are bringing technologies to the table to make data interoperability easier to do, to bring more commonality in how data is shared and digested and used. So the focus can be on care and not on necessarily coding. And so I do hold great hope for all of what I've seen through the pandemic. And I may have been more cynical heading in. I emerged much more optimistic about where we're headed. Challenges will be there, but I believe as a community, the pandemic has given us the courage to test, as Mark pointed out, but more importantly, the boldness for new emerging models to challenge the establishment. Like we've seen in so many other industries, I think it's health time for the challenging of those established norms and the complexities that they bring. And I do believe that partnership between clinicians, care teams, technology companies, the payers, providers, and all the rest of the community are there to take advantage of that. So very excited about the future. Mark, thanks for asking.
We end on an optimistic note. I want to thank our panelists again, Troy Ament, Mark Overhage, Chris Zakalowski, and Shannon Swafford. I also want to thank the technical support of Robbie Morse, and thank you all for your participation.